So, good afternoon, friends. I think we are in this session of complications of diabetes. So, I will be speaking a bit about heart failure and the recent trial, the latest one among the SGLT2 inhibitors, and what new learnings we got from these kind of publications. So, disclosures, I am on the advisory board of these companies which belong to SGLT2 inhibitors. So, heart failure, I think, is one of the complications which is very famous with frequent, forgotten and fatal, which has been reminded to us by the recent CVOTs, and thanks to the CVOTs which has got this complication which was so important to our clinics again, and we realize the importance of heart failure. So we know that there is a relationship between diabetes and heart failure, and the relationship is bidirectional. The prevalence of heart failure is much more in diabetic individuals once there is hyperglycemia compared to non-diabetics. The subclinical myocardial damage is also present in patients with pre-diabetes. When you compare that with the no diabetes, it is slightly more. So maybe it has a linear relationship with the high glucose. That's what it's been seen. Diabetic cardiomyopathy, initially it was traditional thinking that initially it presents as a diastolic failure, then that increases and then goes to the overt failure. Then it was thought of a restrictive phenotype and then dilated phenotype, and there is a spectrum. Now the new conceptual shift of the thinking is that there is a restrictive and dilated cardiomyopathy, maybe two distinct forms of the myocardial damage, and that's what the clinical associations are teaching us. Now when we come to the good glucose control and the cardiovascular risk, and every time we know that even though you push down A1C, cardiovascular risk may not decrease, but when you see the heart failure, how it is associated, the UKPD has showed that when A1C is below 6%, the events for the heart failure are 2 to 3 events per 100 patient years. When the A1C goes above 10%, then the event rate increased quite multifold times. Large kind of studies have shown, say, more than 50,000 type 2 diabetes patients, and you will see each 1% rise in A1C, there's an 8% increase in the risk of heart failure. Similarly, type 1 patients, there's a 30% increased risk of the heart failure. So glucose control do have a relationship with increased prevalence or incidence of heart failure. Despite consistent association, there is no causal relationship has proven with the hyperglycemia. So most studies fail to show a relationship between strict glucose control and reduction of the heart failure. Origin with the glargine, which actually targeted normal fasting glucose, actually showed a bit of lower risk of heart failure in glargine group. Optimal A1C levels in diabetes and heart failure remains unclear that what should be the levels. So as we were saying, it's a bidirectional relationship. By that what I mean, there are lots of studies when there is a patients who were followed up for chronic heart failure, the incidence of development of diabetes is much more in these patients. So there is a relationship which is bidirectional. So there is a myocardial dysfunction. We know there are metabolic risks and metabolic problems which increase the myocardial damage. There is a myocyte and interstitial fibrosis happen, more glycation of proteins, and there is extracellular matrix accumulation which induce fibrosis in the myocardium. There is a microvascular dysfunction with microangiopathy, and we know that type 1 failure is more goes into this type. And of course, there is autonomic dysfunction. So there is a lot of factors in diabetes which increase heart failure. So there are guidelines for the stages, and we know that. So when we see the whole cardiovascular risk, we know all are important, but heart failure becomes a bit forgotten. Cardiovascular complication when you list all the cardiovascular complications in a person with diabetes. So the story started of cardiovascular risk and the anti-diabetes management started from Steve Nissan's paper about rosiglitazone, and then came the regulatory requirement for every anti-diabetic drug that it has to prove that its safety for cardiovascular risk in diabetic patients. So if you see CV outcome trials by drug class, so all DPP-4 inhibitors, GLP-1 analogs and SGLT2 inhibitors, no trial had a primary outcome as a heart failure. So everywhere it was the MACE events, so cardiovascular death, non-fatal MI and non-fatal stroke. But heart failure was not included as a primary event in any of the trial. So the first discussion started about heart failure when the severity of saxagliptin showed increased heart failure in that CVOT. From there, and then of course came the empiric, which actually reduced heart failure significantly and also the cardiovascular risk with mortality. So they coexist. Treatment for diabetes may have variable effects on the risk of developing heart failure. So it should be moved to the part of primary endpoint, which was not seen in so many of CVOTs, which we saw in last few years. So these are the trials which looked at the glucose control and the risk of heart disease. And you know that this is the follow-up as well as the original trial. And we know that UKPDA showed decreased mortality in the follow-up of, so good glucose control, 10 years down the line, cardiovascular risk goes down. That's what UKPDA showed. We know ACCORD increased mortality with severe hypoglycemia as the main background thing, presence. ADVANCE actually was neutral, and even though you push down A1C to 6.5, it does not increase cardiovascular mortality. That was shown in ADVANCE beautifully. Actually, in the follow-up, it reduced nephropathy, the follow-up of ADVANCE. And the VADT again showed slight increased risk. Origin with glargine was neutral. So strict glycemic control has got some evidence which has got some insights into the cardiovascular risk, but no one studied heart failure. The Butler's paper in the EAC 2 years back actually showed us that when the empagliflozin was used, the patients with prior heart failure, yes, SGLT2 inhibitors benefited, but what Butler was trying to show that even patients with no prior heart failure, even though they had a high CV risk, he graded them into the risk of heart failure. So a patient who do not have a heart failure, he graded them into different risk, and even a person with the lowest kind of a risk to develop heart failure with type 2 diabetes, the risk decreased with the empagliflozin or SGLT2 inhibitors. Then the DECLARE was published in just last year, and what it showed that it was the first CVOT where we all know it was the large trial, largest among the all CVOTs, where the molecule dapagliflozin was used. And you can see here is that primary safety endpoint again was initially MACE, that is cardiovascular death, non-fatal MI, and non-fatal stroke. But because the EMPA-REG was published, in the initial plan of the study, in the initial few months, the primary endpoint of heart failure was added, and that was very important, which showed us some insights and improved our knowledge again of heart failure and diabetes with the DECLARE when it was published. We know that there are patients with multiple risk factors in DECLARE as well as patients with established cardiovascular disease. What was the difference here was with the earlier CVOTs, all patients were at a very high risk. DECLARE had a patient, almost 60% of patients were having just high CV risk. So these patients actually represent the patients which we see in our clinics every day, especially patients from the diabetes clinic. EMPA-REG TIMI group, you know, the TIMI group is basically cardiologist clinic. So DECLARE actually represented the patient population which we routinely see on day-to-day basis where the dapagliflozin was used. The DAPA, it established its safety for the MACE, that is, there is no increased cardiovascular mortality or there is no increased non-fatal MI or the stroke with dapagliflozin in this big background population of type 2 diabetes. At the same time, it also showed that hospitalization for heart failure was significantly reduced with dapagliflozin, which was also a primary endpoint, and the composite of CV death and heart failure hospitalization was significantly less, which was mainly driven by HHF. That is, heart failure, again the risk was reduced with the dapagliflozin in DECLARE. Now, even there was some patients, we know that 40% patients in DECLARE had established cardiovascular disease. In the established cardiovascular disease who had a prior MI, in this sick population, there was a reduction in the primary outcome, that is the cardiovascular risk went down in patients with the established cardiovascular disease. So again, the same kind of information repeated which came from the EMPA-REG and the canvas, that if there is an established cardiovascular disease, CV risk goes down. The more sick patients who had a reduced ejection fraction or those who had a heart failure, in these patients with the dapagliflozin in DECLARE, cardiovascular mortality was reduced, all-cause mortality, and again hospitalization for heart failure. So the sick patients were helped more with dapagliflozin, and the not very sick patients, heart failure was significantly reduced with DECLARE. Coming to the renal burden, which is again a very, very common problem in our day-to-day practice. We know that we do have patients with lower GFR, we do have patients with proteinuria, we do have patients with proteinuria with normal GFR, and we do have low GFR who do not have proteinuria. And now we know that the relationship of GFR and proteinuria is a bit complex. It's not that straight, that again we have seen with the recent publications. So in the DECLARE, if you see the renal composite endpoint, again it was reduced significantly with dapagliflozin. Also, the hospitalization for heart failure in this sick population with the reduced renal function was significantly reduced. You can see here the p-value was significant in the DECLARE. Dapagliflozin, like other SGLT2 inhibitors, reduce albuminuria regardless of the baseline, and also it reverses or it prevents worsening of albuminuria. That was again the renal composite endpoints which were recently published from the DECLARE trial. So this was a very nice, once we have this EMPA-REG canvas and DECLARE, and you will be listening to these trials every now and then, so I will recommend to see this systematic review of SGLT2 inhibitors. And one can see that when you are seeing these CVOTs, whenever you see a conclusion, you should go back to see what was the study population, so that whenever a trial's results come and you try to apply that to your patient, you should apply them to the whatever study population in that trial was enrolled. So a very high risk patient like EMPA-REG, all patients had established cardiovascular disease. You see there is a significant reduction in cardiovascular risk, also the mortality. If you go back to the not very serious patients, like there were 60% of them in DECLARE, here again the primary endpoint of heart failure was significantly reduced, even though patients never had an established cardiovascular disease. And that was a new learning from DECLARE, that it is helping these patients even though they are not high CV risk. So that came from DECLARE. As we know that, how do you know that how is the background population? If you see the placebo group and the event rate, which is a natural progression of type 2 diabetes for 3 to 5 or 6 years, DECLARE took more time because of the patients were not very sick. So to get so many events, there were more months and more time which needed to end. And you can see it was a low risk population. If you see in DECLARE, actually the MACE endpoints and cardiovascular mortality in the placebo group was much less compared to the EMPA-REG. Still, heart failure was reduced. So when you see there are sick patients, the SGLT2 inhibitors, those who already have an established cardiovascular disease, they reduce MACE, like non-fatal MI, stroke, and cardiovascular death. Hospitalization for heart failure and cardiovascular mortality is also reduced in patients who do not have established cardiovascular disease, almost 60 to 70% of patients who are sitting in our clinics. Now, composite renal endpoints, SGLT2 inhibitors have a fantastic renal outcome and they protect kidneys. In a minute, I will come into a very interesting slide. It's consistent and impressive. Now we have the credence which showed the canagliflozin, but all of them, they have impressive renal benefits which are seen in patients with established cardiovascular disease as well as patients who do not have established, just high risk cases. So all SGLT2 inhibitors work best when there is a preserved renal function. They work best even to protect kidneys. When the renal function goes down, there is a still benefit from SGLT2 inhibitors, and in this sick population, the benefit is much more for cardiovascular mortality and a hospitalization for heart failure. So these sick patients are protected much more with SGLT2 inhibitor, though their major effect is actually seen better in preserved renal function. So both the population, there is a good kind of a protection to the kidneys with SGLT2 inhibitors. So actually the knowledge about the diabetes and established CV disease and the patients with just multiple risk factors, we know that MACE was prevented. Here with the empagliflozin and the CANA also a bit part. Here heart failure was preserved. What DECLARE actually showed that MACE is reduced in the established cardiovascular disease, heart failure is reduced even with patients with the low cardiovascular risk, and the renal benefit is seen in both the population, whether there is a primary prevention or whether it's a primary prevention or a secondary prevention. So they are good for the kidneys, and that additional knowledge we got in last few months. What about existing heart failure? So we do have trials which are going like DAPA heart failure trial, which is testing the dapagliflozin in patients with heart failure with reduced ejection fraction. If you know, the EMPA-REG, CANVAS or DECLARE, the baseline population, how many patients had established heart failure? It's only 10 to 11%. Rest 90% of patients never had a prior heart failure. Still it showed a reduction. So the question came, are these heart failure drugs like ARNI, are they preventing heart failure? What are they doing exactly? So to test this now we have these studies going on, which is DAPA heart failure as well as the EMPEROR with that, which is actually testing that whether patients without diabetes with heart failure, whether these will be helped by dapagliflozin, that is DAPA heart failure study is trying to search. So there's some key questions that what is it exactly working? Actually, it happened like this. Saxagliptin showed some heart failure. So there's lots of meta-analysis, retrospective studies, real-world studies started looking into heart failure. Heart failure was never included in the major cardiovascular risk when we talk in type 2 diabetes, which now we are looking at differently. So it just showed that whenever we say cardiovascular risk in a diabetes person, it's different for carotids and cerebral. It's different for coronaries. Atherosclerotic risk is different. Heart failure risk is different. And maybe the myocardial damage risk may be different. So when you are saying cardiovascular risk, it's not correct to put up everything together and just say that cardiovascular risk. We need to look down at each point separately. So the question was, is the jury out? That when we see about kidney and the heart, and the diabetes, and we know there is a lot of links, and now which are talking about beta cells in the kidney, how they are going to start working, which may be preventing lots of problems. And so should SGLT2 inhibitors be the add-on to metformin for most people with type 2 diabetes thinking about the CV risk? So we know that ASCVD present a patient with PTCA bypass or a positive TMT or an event, we know that they are a must. Along with metformin, I might say just not as an add-on. It can just start with a combination. We know that whenever there is a heart failure predominates, these are the drug of choice and may come in non-diabetics once these trials publish. Patients with CKD or just proteinuria or lowering GFR, we know that there is a great statistically, you know that when this credence was present, you know the statistical thing was dramatically announced in Australia that 0.00001. So we know that patients with low GFR are getting benefited with SGLT2 inhibitors, but let me remind, SGLT2 inhibitors work best with preserved GFR and also help patients with lower GFR. What DECLARE actually showed us that patients without established cardiovascular disease do get benefit for decrease in the heart failure and protecting the kidneys. Thank you so much.